Friends, good morning everybody. Today let's discuss on the investigation and treatment of COVID-19 as on today. Before moving on to investigations per se, let's discuss its pathogenesis. So the SARS-CoV virus 2 is going to enter your nasal cavity and it is going to replicate. Then through ACE2 receptor it is going to enter your cells. So the main cell that is targeted in lungs are the type 2 alveolar cells or the type 2 pneumocytes. So there will be damage to type 2 pneumocytes. Type 2, the normal function is to secrete surfactant and to maintain your gaseous exchange. So type 2 pneumocytes are affected, which leads to pulmonary damage, which in turn leads to hypoxemia, which in turn is going to result in the final stage, which is known as acute respiratory distress syndrome. This is the overall pathogenesis. Okay, now what happens when your virus is affecting your pneumocytes? Okay, there will be more inflammation. More inflammation means release of inflammatory markers, that is inflammatory cytokines. The main cytokine involved here is IL6. Normally in any inflammation, when IL6 is secreted, that is auto-regulated or regulation is intact. But what happens in COVID-19, there is no proper regulation of IL6 and which leads to a condition known as cytokine storm. There is more and more inflammation that is taking place. Okay, so there is another entity which is known as hypoxemia, which results due to improper functioning of the pneumocytes and decreased gaseous exchange, leading to decreased partial pressure of oxygen. This hypoxemia can be direct or indirect. Indirect hypoxemia is also called happy hypoxemia, which means that the patient will be happy but your SpO2 will be less than 88 to 90%. Okay, now we'll move on to the interleukin 6 per se. We'll discuss about IL6. So this is a predominantly pro-inflammatory cytokine. Okay, it is going to induce inflammation. Pro-inflammatory cytokine. This is going to stimulate your hepatocytes to release the acute phase proteins such as CRP, amyloid A, fibrinogen, hepcidin. CRP, as you know, it is elevated in all inflammation. Amyloid A, chronic condition, leads to amyloidosis. Fibrinogen, there is an increased risk of cardiovascular events. And hepcidin for iron storage. It also decreases the production of albumin. Albumin is required to maintain the oncotic pressure. Decreased plasma oncotic pressure leads to what is known as edema. Okay, and in the bone marrow it is going to stimulate your platelet production. IL6 is going to stimulate your platelet production. Okay, and coming on to the immunology aspect, it is going to increase your CD4, CD8 T cell. And it suppresses it. If it is unregulated, it leads to, this condition leads to autoimmunity or chronic inflammation. And IL6 also stimulates your T helper 17 cells and it inhibits your T helper regulatory cells. Apart from this, IL-6 also stimulates your B cells to produce your antibody IgM, IgG. It also promotes your production of VEGF, that is vascular endothelial growth factor, leading to angiogenesis. So these are the functions of IL-6. So now this IL-6 cytokine storm is going to increase all this in your body. Okay. So moving on to the investigation, let's see what are the investigations required for the patient. So in any patient, first you do CBC, complete blood count in pathology. So what do you suspect here? You can see leukocytosis if the patient is having mild COVID-19. If the patient is having severe COVID-19 disease, you can suspect leukopenia. And your ESR will be elevated. Then you can check your procalcitonin level. Procalcitonin is not particularly for this COVID-19. If there is any secondary bacterial sepsis, you can rule out or identify. Next, the biochemical parameters are CRP, ferritin, IL6, D-dimer, okay, and LDH. C-reactive protein is increased in inflammatory conditions. Ferritin is also an acute phase protein. It is elevated. D-dimer. Why D-dimer? Because when there is injury to your blood vessel, there is release of, or there is platelet aggregation. When platelet aggregates, it forms a thrombus. To dissolve the thrombus, there will be fibrin degradation products, and so your D-dimer assay will be elevated. Okay, now let's move on to the treatment aspect. So prophylactic treatment is given by vitamin B complex. Vitamin B complex is a part of almost all the reactions. For example, thiamine, pyridoxine, niacin, B12 all are acting as cofactors for multiple reactions. So it will be enhancing your energy levels. So here fatigue is taken care of. Vitamin C is going to increase your or boost your immunity. It is also acting as an antioxidant. Next, vitamin D. Almost all the Indians are deficient in vitamin D levels. So vitamin D is going to improve your immunity. A dose of 60,000 international units once in 2 weeks is given. Then comes your zinc. This is also cofactor for reactions, and it also increases your immunity. Okay, this is your prophylactic drug. Next, mild cases you can treat with tab, paracetamol, Sidzin. Then you can give some antiviral drugs. And antibacterial drugs, secondary option if there is any bacterial infection, wherein we give azithromycin. So the antiviral drugs are oseltamivir and remdesivir. So these two drugs will be inhibiting your viral replication by inhibiting your polymerase enzyme. RNA polymerase enzyme is inhibited. Okay. Next, what do you give to the patient? You give oxygen support in case of severe COVID. So the mnemonic to remember all these is PAAS. P stands for prone position. The patient has to lie down. His face should be facing the floor. what is the importance of prone position? When you lie prone position, what happens is your lung bases will expand because there is no much pressure over your diaphragm. Your lung bases will expand, leading to more gaseous exchange taking place and more ventilation. So prone position is important. Oxygen support, if you want, you can give. Then antiviral drugs that we have already seen, oseltamivir and remdesivir. Then anticoagulants, because if there is any thrombus formation, you require a low molecular heparin or enoxaparin to anticoagulate the patient. Then comes your steroids. You can give either methylprednisolone or dexamethasone. Okay, in very severe cases, what do you give? You can give tocilizumab and hydroxychloroquine. These drugs should not be given for all patients. You have to think twice, thrice before giving, because tocilizumab is going to suppress. This is your monoclonal antibody against IL6. It is going to suppress your inflammation. It is also going to suppress your immunity as well. So immunosuppression is very common side effect of this drug. So you have to think before you give. Hydroxychloroquine is also given, but in severe cases, but you will have to think about its side effects. Only in those patients who require it should be given. The mechanism is, it is going to increase your intracellular pH. So when it increases your intracellular pH, there will be no viral replication. Okay, this is your mechanism, and it is also contraindicated in a number of diseases, immunosuppressive cases, hepatitis patients, G6PD. Okay, and finally is your ventilator. So this is your investigation and treatment modality as per today. There is no particular drug as of now, particularly for COVID-19 disease. So all these drugs are used for some other disease. They are acting as a supportive drug for COVID-19. Okay, thank you.